Good morning, dear chair and dear audience. Welcome to my 12-month progress report. It's quite a long time, isn't it? So it's a year, and we are looking back to a quite successful year. And the first time I was standing here, it was snow and freezing cold outside. I don't know if we can imagine freezing cold right now. I can't. I don't know whether you can, but it's really good to look back, and I'm hoping that that's the same for you as well. So I'm Lőrinc Frivaldszky. I'm a resident from the Children's Hospital, and with our team we are looking to improve the quality of life for women during pregnancy and in the postpartum period as well, by finding methods that can prevent and treat certain complications related to these periods. We have two projects ongoing right now. Both are meta-analyses, and the first one is submitted, and the second one is still in the working stage. And I'm planning to tell more about the first one in my presentation. So the first one is about investigating the efficacy and safety of esketamine to prevent postpartum depression, or PPD, in women undergoing cesarean section. PPD is a prevalent but treatable disorder that affects 14% of women after pregnancy, and it features included a quite diverse spectrum of symptoms, including sadness, sleep disturbances, and even suicidal behavior as well. So women undergoing C-section are quite at risk for this disorder. And currently there is no preventive treatment known for PPD. Esketamine is a promising drug. We use it for, psychiatrists use it for treating depression, and it's used as an analgesia in perioperative settings as well. And we have some data that is promising that esketamine can be used for preventing PPD. So our aim is to assess the efficacy and safety of this drug for the prevention of PPD. We are using the PICO framework to answer our question. We are looking at women who are undergoing cesarean section, and we are using esketamine perioperatively, either a one-time infusion or a longer infusion for most of the times 48 hours. And we are comparing these treatments to placebo or standard of care, and we are looking at certain outcomes. First of all, the rates of PPD after the treatments or placebo, and of course we are tracking the safety outcomes as well. And we believe that esketamine perioperatively is superior in reducing PPD risk compared to placebo. We used this search key in 5 databases, and in the end we ended up with 8 eligible full texts for this analysis. I would like to present a few plots from our results. On the first plot you can see our primary outcome, the rate of postpartum depression measured on between 3 to 7 days after giving birth. You can see on the left side the incidence rates after giving esketamine perioperatively. On the right side you can see the control, the placebo group. It's quite a heterogeneous group, but in the end we ended up with an OR of 0.32, and it means that we were able to reduce the risk for PPD in a quite high volume, and it's even significant mathematically as well. On the second plot, you can see one of our secondary outcomes. It is the EPDS scores, the Edinburgh Postnatal Depression Scale. It's a screening tool used for assessing PPD risk. And as you can see, on the left side, the esketamine group, on the right side, the control group, and we measure the mean difference of the EPDS scores of these two groups. And in the end, we concluded that after giving esketamine, there is a 1.42 decrease in the EPDS scores favoring the esketamine group. This means that we can reduce the EPDS scores with this treatment, and in this case, this is significant mathematically as well. We measured a few side effects that are related to giving esketamine, and we concluded that although some of are in a greater number, for example in dizziness, appearing in a group receiving esketamine, but in the end none of them were significantly higher in the treatment group. The strength of our study is that we used only RCTs, so we have a low risk of bias, but the low number of cases and the different definitions of PPD among studies can be a limitation among others. So, in conclusion, we can say that esketamine perioperatively can safely and effectively prevent PPD in this population. So guidelines should consider using esketamine for this goal. But our limitations suggest that there is a need for further studies with longer follow-up time, diverse populations, and different dosages and administration types of this drug. And we are currently waiting for our 5th submission to get a response. So we are hoping to get accepted in the near future. Our second project is still ongoing. It is investigating the efficacy and safety of interventions for treating nausea and vomiting in pregnancy. This condition is it's quite common. It's affecting 80% of pregnant women during pregnancy. In most cases, it can be quite mild, but in some other cases, it can turn quite serious and can result in malnutrition, depression, and even bad outcomes for the baby as well. There's a wide range of interventions that are used in practice, but the data for their efficacy is quite unsatisfactory. So we aim to assess the efficacy and safety of these interventions against NVP. So we are using the PICO framework for this question. We are looking at pregnant women with this disorder. We are assessing different interventions against it compared to placebo. And we are looking at the efficacy of these treatments, number of vomiting episodes, different scores that can assess the quality of life of these women, and the safety outcomes, of course. And we believe that there are some interventions that can safely and effectively prevent and treat nausea and vomiting in pregnancy. We are still in the search and selection phase with this study, so we use the following search key with 3 domains, and we are currently looking at 185 eligible abstracts, and we are performing the full text selection right now. So we are at this stage with this study, and we are hoping to finish this study in this year. So thank you for your attention, and I'd like to finish my presentation with a quote: "A cheerful heart is good medicine, but a crushed spirit dries up the bones." So thank you.
Congratulations. I was just wondering if the RCTs that you included in your first meta, did they use the same administration route for esketamine and the dose? What it was comparable between the studies?
Yes, it was comparable but different. So they used a quite narrow range of dosages, but these were different ones. Some studies even compared 2 different dosages or 3 different dosages to each other and to placebo. And they used different methods for administration as well. Some were one-time infusion after giving birth, and some of them was the PCI, the patient-controlled analgesia, for a longer time, for most of the time 48 hours. But these were also comparable because of the dosage they received in the end.
And so it was intravenously?
Yes, yes.
And didn't they use benzodiazepines as well?
In some studies they used it as part of the standard of care, but only in few studies.
Thank you.
Thank you for your presentation. Actually, my question is similar to his, but I want to ask, you said also benzodiazepines in some of the studies were registered.
Yes.
Do you think they are maybe more favorable, or in the study they mentioned which one is better, or something else?
I don't really have the data to say the exact answer, but they used benzodiazepines as the standard of care, so they give it both to the treatment and both to the intervention group, to the comparison group. So I couldn't really assess the superiority of these drugs to the main drug.
Thank you.
What about the women with a history of drug abuse? Were they excluded from the articles? Should we fear about addiction in these women?
So it's a very good question. Thank you. All studies excluded these women in the trial phases. So we don't have data about this population, but we should have. So for further studies, it's a really good question to ask.
Is there consideration for repeated use, like not just after delivery or cesarean section, but later? Like how long this risk for postnatal depression, postpartum depression last?
I mean, it's quite a new treatment even in Europe, and I mean, the studies didn't really try it for repeated treatments or for a longer time. They were very cautious and just let's give it one time and let's see what happens. So we don't have data for repeated treatments.
Thank you.
Thank you, Lőrinc, for your presentation. I'm sure you've been asked this question before, but I would like to ask again. Why only cesarean section? What about vaginal delivery?
Yes, thank you for the question. So we have two reasons for that. So the first one is practical, because esketamine was sometimes used in analgesia during cesarean sections. So that's the practical side. The theoretical side is that this population, women with C-section, are at higher risk for PPD. It's a complicated question. The experience of the cesarean section, the bond between the mother and the infant. So it's a complicated question why there is a greater risk, but there is a significant risk for this population.
All right. Is esketamine available in Hungary? Do you use it in your clinical practice?
I don't use it. I'm a pediatrician, okay. But if I would be a psychiatrist, I may use it, I think, for depression treatments.
All right. For your second project, I know it's still in the full text selection, but you've mentioned in your intervention that you would like to compare different interventions to treat nausea and vomiting in pregnancy.
Yes.
And you have already 185 articles for full text selection.
Yes.
Could you tell us a little bit more about what kind of intervention you found so far?
Yes, thank you. So it's quite a wide range of interventions. There are pharmacological ones, there are non-pharmacological ones, alternative ones that include aromatherapy or acupuncture. So it's quite a lot. It will be a very diverse meta in the end, I think.
I also would like to have a question. After all these great questions, what you got. So we know that the epidural anesthesia has a negative effect on the breastfeeding, and we also know that in the case of the cesarean section, it's also a bit more difficult. Do you have any data about the esketamine, or do you have any comparison with the esketamine versus non-esketamine, whether the breastfeeding and how does it work and how efficient is it? It is changing, or is it successful?
It's a crucial question, thank you. The studies don't have data about breastfeeding, but further studies should definitely consider this aspect. What I can say about esketamine in the perspective of breastfeeding is considered to be low risk during breastfeeding. But in this case, the very low overall dosage has no effect on breastfeeding, I mean on the infant. So for the breastfeeding itself, we don't have enough data yet. That should be a goal for further studies, of course. Thank you.
Thank you very much.